A 48-year-old man was presented in November 2009 with decreased visual acuity, pain, ocular movements, photophobia, and infratemporal visual distortion. This is associated with a mild ataxia and a 9-day history of severe dull frontal headaches not worsened by the Valsalva maneuver. He had no past ocular history, and his medical history consisted of sciatica and cirrhosis. Ocular examination revealed decreased visual acuity of 6/24 OD and 6/6 OS. Dilated fundus examination revealed an isolated finding of bilateral optic disc swelling with associated splinter hemorrhages on the right. There was no evidence of restriction in ocular motility, such as sixth nerve palsy, which is known as a false localizing sign for raised intracranial pressure, nor was there any other cranial nerve palsy identified. Reliable Humphrey visual field tests showed bilateral diffuse field loss. Following admission under the medical team for presumed raised intracranial pressure, B-blockers were commenced to relieve the headache, and radiological and hematological tests were performed. Chest x-rays and computed tomography were inconclusive. Magnetic resonance imaging of the head and orbit showed only nonspecific changes and did not appear to be of clinical significance. Ventricle basal cisterns in sulci were normal and symmetrical. Initial blood tests, including antibodies and syphilis serology, were also negative. On review 2 days later, his visual acuity was further decreased to 6/24 OD and 6/36 OS. Ishihara testing revealed a significant decrease in color vision in 4/14 OD and 3/14 OS. Intravenous high-dose methylprednisolone was initiated for 3 days, followed by oral prednisone for 40 mg daily, tapered at 5 mg weekly. A lumbar puncture was performed, which revealed a normal opening pressure, helping to exclude papilledema in the presence of finding of bilateral optic nerve swelling. Further analysis of the cerebrospinal fluid found white cells and glucose levels to be within normal limits, and there was no evidence of microorganisms on the microscope. Red blood cell count was slightly elevated, but in the absence of intracranial hemorrhage on the cranial imaging, it is likely that there was secondary to the traumatic tap. Further blood results revealed a positive result for Bergdorferi by Lyme enzyme linked to immunosorbent assay and Western blot serology. The patient had no recollection of any recent tick bites, but had sustained bites previously. Therefore, the diagnosis of Lyme disease was made in the absence of erythema migrans because there was a history of exposure to the endemic area, involvement of the last one organ system, and positive results from the laboratory.